Okay, great. So just a minute. Yes. So I have just taken the liberty of changing the title of this topic basically from just HLA testing to, I think, what I'm actually going to do exactly in the next few minutes is talk about the clinical interpretation of HLA based testing. So we will talk more about the clinical aspects and the background where these HLA based tests are required and what do these tests mean for a solid organ transplant or for a stem cell transplant, etc. We'll not go into the technical details of the testing here. So, as I said, the role of HLA laboratory is pivotal in cases of transplants. And as we've seen in the last couple of decades, a lot of transplants do happen. Bone marrow transplants, solid organ transplants, they happen in almost all the major cities across India. So the role over here of the HLA laboratory, which is very commonly associated alongside the transfusion laboratory, is to actually interpret and provide information that will help us understand the risk of rejection, either acute rejection or chronic rejection whenever there is a transplant. And it also assists in determining if any clinical event is of rejection is happening. So in monitoring also post-transplant. So pre-transplant, we do certain HLA based tests just to be sure that the transplant whichever we have planned is going to be successful and acceptable immunologically, and then after the transplant we monitor the patient for various events proactively, like rejection, acute rejection, chronic rejection, etc. Right? So if you look at the type of testing, very broadly we can say that the testing will include typing test, so HLA typing. That means you have a donor or a recipient and you need to know the HLA type, which is the first step towards your transplant, whatever it may be, either a bone marrow transplant or a solid organ transplant, renal transplant, etc. Sorry, where
Sir,
are the
your skin is
slides?
not visible.
Yeah, I know the slides have also. Yeah, can you see the slides now?
Yes.
Okay, so typing, as I was saying, not only for the donor and the recipient typing, but there are certain HLA typing tests that are very specific because they are associated with a particular disease. So disease association, and the commonest which all of us know is typing for HLA-B27. The other important application of typing based test is chimerism testing. So chimerism, as we all know, where there would be more than one or generally two different cell populations. So one is derived from the donor origin and the other from the recipient origin. And you look at the chimerism picture after a stem cell transplant in order to monitor the progress of that particular transplant. So typing is one broad category of HLA testing. The other broad category of HLA testing is to assess alloreactive response. By this I mean is testing for your donor specific antibodies or testing for the T cell response. So as we all know, there are various antibodies which can be formed as a result of sensitization to various HLA antigens, and testing of these antibodies, monitoring the antibody levels will be a very, very important challenge when you are dealing with any solid organ or a bone marrow or a peripheral blood stem cell transplant. Right. So let us first start with some basics. As all of us know, HLA stands for human leukocyte antigen, and it is a gene complex encoding the major histocompatibility complex proteins in humans, right? And it is expressed on the surface of almost all the cells that are responsible for lymphocyte recognition and antigen presentation. We all have read about this in our immunology, right? Histocompatibility, as I said, is crucial for pre as well as post transplant management, and HLA antibodies are key in getting and keeping the allograft safe and alive. So antibody testing methods, as I said, are used to assess the immunological risk. So you understand the severity of the problems that you may be facing in the post-transplant period. And a lot of laboratory expertise is needed to interpret these testing results. So this is truly a multidisciplinary approach where you have the immunologist, you have the transfusion medicine specialist, you have the HLA laboratory members, and they sit together and then give their opinion about the suitability of a particular donor in a particular scenario pre-transplant. Also, clinical expertise is needed for understanding the clinical significance of the various antibodies that we land up testing in the HLA laboratory. So let us try and understand again a little basic information. So this HLA is related to chromosome number 6. The short arm of chromosome 6 in this particular region, you can see that there is the HLA region. And basically, when you are talking about HLA, you will deal with class 1 HLA, which includes A, B, and C HLA types, and class 2 HLA, which includes the DR, DQ, and DP types. Of course, there is class 3 and various other HLA about which we can read in our textbooks. But currently, what we will do, as is shown in this table, is try and understand the most important, clinically important class 1 and class 2 HLA. As I said, the gene products, say class 1 has got major, that is HLA A, B, and C, and minor gene products like E, F, and G. Okay, these are all present on nucleated cells, and their function is identification and destruction of abnormal or infected cells by cytotoxic T cell mechanism by presenting it to CD8 positive cells, right? Whereas HLA class 2 will include HLA DR, DQ, and DP, and there are some minor like HLA DM, HLA DO, etc. Now these are typically present on B lymphocytes, macrophages, dendritic cells, activated T cells, and endothelial cells, and they do the function of identification of foreign antigen and presenting it to the helper T cells, which are CD4 positive cells, right? So HLA typing is also known as tissue typing, and it is important. So traditionally, this was first implemented in evaluating the family members of in the kidney transplant scenario, basically, because the basic fact is that the family members will share at least one haplotype, with each other. So HLA typing, in order to ascertain that people who are donating the kidney to one family member, so they are indeed, establishing the same relationship as they are claiming. Okay, so degree of match is an important consideration in choosing the correct donor from the family member, because all of us may not match to the same extent within the same family also, right? As I said, each individual will inherit one haplotype of HLA genes from each parents. So in the renal transplant scenario, which is the most common solid organ transplantation done worldwide today, you look at the HLA-A, HLA-B, and the HLA DR. So you do A, B, and DR typing. So DR beta 1 antigens, these are regarded as the most important consequential HLA in the renal transplant scenario. Okay, so when we are talking further about HLA and transplantation, what we need to know is how to read the HLA. So there is the WHO nomenclature system, where first you will have the prefix, which is the HLA. So you may have HLA-A, HLA-B, HLA-C, or HLA-DR, and so on. So that is the prefix, which is followed by a hyphen, which is used to separate the gene name from the HLA prefix. And then you have the A or B or DR or whatever, that is the gene. After which you have a asterisk, which is known as a separator, which is followed by the first field. So here you have HLA-A O2. Okay, again after that you will have a field separator, and then there will be the second field, the field 2, which is the specific HLA protein. Again there will be a field separator, and then there will be field 3, which is used to show a synonymous DNA substitution within the coding region, right? And then towards the end you will have the suffix. So you can forget all the complex things that I said just now, but here practically important for us is to understand the resolution of HLA typing, so which I will talk about in the subsequent slides. So these are the basic instruments that we use in our laboratory for HLA typing, where amplification of the DNA is done by PCR, and that amplified DNA product is then typed either using a Luminex based platform, which is this, or a Mr. Spot named equipment. So this is basically SSOP technology that we use. So basically, if you look at the various methods of HLA typing, it has evolved with serology as the basic method of typing, which was non-sequence based typing, and where antibodies specific to HLA proteins were used. So the typical 96-well platform was used for manual typing, serotyping. So long back when I used to work at Tata Memorial Hospital, I have seen the senior scientists do serology typing for HLA in our laboratory. Then very soon we had the SSOP, that is sequence specific oligonucleotide probe, where the PCR product is tested against a series of known probe sequences. And then from the pattern of the probe annealing, the allelic type can be deduced. Also, there is SSP, which is sequence specific primers, or you have Sanger based typing sequencing by termination. So SBT is also available. And then today, the most popular one, the highest resolution, will be given by your next generation sequencing, where you are performing long range PCR to amplify the HLA genes, fragment the HLA genes, and then perform the deep sequencing. So that is how the different methods of HLA typing can be viewed at. Now, I talked about the resolution. So you can see with serology, it was possible to only go up to the first field, basically one field. So you have, suppose you have typed HLA-A, and the type of HLA-A up to the first field, say O2 or O3, only that information can be derived with your serology. So this is the low resolution typing. If you are able to go beyond the first field to the second field, then that would be the next level or the intermediate level of resolution for HLA typing. So here you have HLA-A, O2, O1, right? In the next level, you will go up to the exonic sequence level, which is the third field of typing. Okay, so this will be the high resolution typing, where you are reporting it as HLA-A, O2, O1, and O1. Okay, and then finally the full DNA sequence also, or the fourth field of typing, where you can go till the level of HLA-A, O2, O1, O1, and 134, right? So that is basically the clinical relevance of resolution. So generally these days for the solid organ transplants, a low and medium resolution typing is still okay, right? Because you are not actually doing a complete matching, but a complete match between the donor and the recipient, a 10 on 10 or a 12 on 12 match, is necessary for the bone marrow or the peripheral blood stem cell transplantation scenario, hematopoietic stem cell transplants. And there you do a high resolution typing. So next generation sequencing is very commonly used for large scale high generation typing. So this is the output, the equipment output of a HLA typing. So this is typically showing you a ABDR report after your HLA typing, the testing. Next, we'll try to understand about the antibody testing. So again, here we are not doing the molecular typing, but we are looking at the antibodies, and cell-based assays are subject, as we know, are subject to false positive results, which may be caused by either non-HLA antibodies or auto-antibodies, etc. And there may be antibodies in very low titer or very low level, which may still have some clinical relevance. So these assays are now routinely augmented by solid phase assays, which have significantly improved the sensitivity and specificity, right? So if you look at the solid phase assays or the various assays, cell-based assays that are available. So basically the lymphocytotoxicity test, where we have the testing for T cell and B cell. So basically the CDC cross match. complement-mediated cytotoxicity or complement-dependent cytotoxicity test is the CDC test. So all of us must have read about this test, which was the basic requirement. And even today, the nephrologists or the transplanters, they look at the results of CDC first, because even the regulations, the national, international guidelines, they mandate a negative CDC. So if your CDC is negative, then you can go further, investigate further and go ahead with the transplant. So how today the CDC has been enhanced. So in 1969, basically, Patel and Terasaki were the scientists who described the basic CDC methodology, which was then standardized, and the NIH protocol for cytotoxicity testing was published in the next year. And then later on, you had various modifications to these CDC methodologies, like adding the anti-human globulin to enhance the cytotoxicity or the sensitivity of this test. Then very soon we had the ELISA-based test and the flow cytometry-based assays. And today, the solid phase assays are available, and we use a combination of different assays, at least 2 different technologies, to make the clinical decision in this transplant scenario. So a little bit about solid phase assays. So here what we do is we have these various polystyrene beads that are available for testing, and these beads are coated with various HLA antigens, right? And in this equipment, which is known as the Luminex, as the name suggests, there are various laser beams through which these beads will pass. So what happens is that if there is an antibody or multiple antibodies, depending upon what antigen is coated on this bead, this antibody will attach to this bead, the antigen coated over the bead, and then it will be tagged with a phycoerythrin based anti-IgG antibody, and it will be detected, and it will give a output which will be measured in terms of mean fluorescence intensity, or MFI, which we call as a short form MFI values, and those will be used for correlating the quantum basically of the antibodies that are detected. So if you look at solid phase immunoassays, they have really revolutionized the field of antibody testing, because they have improvised the sensitivity, specificity, the time that is taken, and the efficiency of the testing for antibodies. And they have also reduced the reactivity of the antibodies to non-HLA antigens, which can be like an interference basically when you are evaluating a patient for any donor-specific antibodies, right? So test for antibodies to most, but not all the HLA antigens with the help of commercially available kits is now possible. So there are different manufacturers like Luminex, GenProbe, One Lambda, etc., who provide these antibody testing solutions. So over here, so these are basically bead-based assays. So I would like to explain the basis of these bead-based assays. So you may have pooled HLA antigens, where there is either a lysate or class 1, class 2, and a mixture of class 1, class 2 antibodies, and you may just perform a screening. So first, let us understand the lysate-based cross-match, where you perform the lysate of the donor white blood cells, and then you interact it with the plasma of the recipient. So if there are any antibodies in the recipient which are directed against the donor, you will get a reaction, a positive reaction, which will be quantified as a MFI value. So this is known as a Luminex cross-match. Basically, it is just a lysate cross-match. One step further, you may be doing a screening or panel reactive antibodies, where for class 1, you have 7 different beads on which various different classes of HLA antigens are coated for class 1. And in the class 2 library, you will have 5 different beads in which 5 different class 2 antigens are coated, and you will get a fairly good idea against what particular class or any particular HLA type there are antibodies in the recipient. And then if you want to actually find the specificity of the antibody, then you go ahead with a single antigen bead assay, where the beads are coated with recombinant single antigens. So they do not have mixtures of different HLA antigens. So one antigen is attached to one bead. So as far as the order of sensitivity is concerned, the single antigen bead is the most sensitive, followed by your DSA and screening. So this is how the report looks for the class 1 and class 2 screening. You can see here the class 1 results and the class 2 results. In class 1, there are 7 beads which have been noted over here. And for class 2, there are 5 different beads, and you have a positive and a negative control, and you have the patient screening results over here, right? Which you quantitate in terms of, again, mean fluorescence intensity, MFI. Right? So let us go further. Yes, this is the single antigen bead. So you have the various HLA antigens that are noted over here, and then the reactivity to all these, the big list of HLA antigens over there with in terms of the MFI values you will get in this region. Right? So this is the single antigen bead test. Right? So as I said, there are 3 different formats which we have seen for the antibody testing. So how do these antibody testing help us? How do these results help us really in decision making? So first thing that I want everyone to understand is that antibody result is like a snapshot in time, basically. So you have to understand it in the correct perspective, because changes in antibody results will keep on happening, and a single result is not as important as a trend that is observed in the various results. So just doing one antibody test and then saying that, okay, everything is fine, can be misleading actually. You have to do testing at various levels, at various time points during the transplant process. The next important aspect is that antibody tests are strongly correlated, but they do not perfectly predict outcomes. You may have a case where there would be a fairly strong antibody. So how do we decide whether it is strong or weak based on the MFI values? But we have seen patients where the MFI values are about 10,000. So we consider that as very clinically significant, but the transplant outcome is not all that bad. You are able to still do a successful transplant. But there are rarely also patients where the MFI values, antibody levels are only in the range of say 2000 or 3000 MFI, which may be considered as clinically not very significant, but the outcome is very dismal, right? So we have to keep that in mind. Then the optimal monitoring frequency for post-transplant antibody testing has not been established. So if you talk to institutes, they will have their own protocols. Some of them will screen only once or twice after the transplant, whereas there are others who do, testing every month for the first 3 months, and then every 3 months, followed by every 6 months, and taper it off, right? So these antibodies, they may predate clinical outcomes by months to even years. Okay, so today you may have a donor specific antibody detected, but clinically everything is fine. So you may not be really worried. But when you follow up these patients, the antibodies have given you some telltale signs that maybe 6 months or 1 year down the line, there is going to be some rejection or some problem that may affect the graft survival, right? Also, as I said, the antibody presence and the MFI value do not reliably predict the severity of the pathology that we are dealing with. So don't just understand the MFI values, or don't just go by the MFI values, and don't just go by one single test. At least perform 2 different tests of 2 different principles basically. Also, the DSA and MFI at rejection diagnosis do not reliably predict responsiveness to treatment. That's also one more important aspect. Class 1 is generally considered to be of more clinical significance, but class 2, especially against the DQ, they correlate with late rejections, worse function at diagnosis, and less responsiveness to treatment. So if you are identifying an anti-DQ, HLA-DQ antibody, it may be also clinically significant. So don't just dismiss it because it is a class 2 antibody, right? Dynamic changes in MFI with treatment of AMR often reflects changes in the clinical status. And as I said, DSA MFI may decrease with treatment of rejection, but you will never get a very clear negative or complete disappearance of the antibody. So you have to look for the falling trends of the MFI values or the antibody that are present, right? So further about the effect and interpretation of these antibodies, as I said, they may be present even before the transplant, or they may be formed later on de novo during or after the transplant also, right? Any antibody test can change within as short as 72 hours. Why? Because of the memory B cell response. And therefore, whenever you are doing a transplant or planning a transplant, the last final go ahead test should be done within 48 to 72 hours of the actual transplantation, when the organ is going to go in or when the infusion is going to happen. Because as early as within 72 hours, an antibody may be formed. Then not all patients with DSA pre or post transplant will have an adverse outcome. So don't panic. Serial testing, as I said, before and after the transplant will be very informative, and the timing of routine testing in patients who are asymptomatic and stable is determined at the program level. That means at the institutional level. Latency period is modified by many variables, particularly adherence to immunosuppression. So follow-up of the patient will be very, very useful in all the post-transplant cases, right? So as I said, don't just look at the MFI value, look at it, interpret it in the context of clinical function and your pathology reports, also the histopathology reports. DSA and MFI cannot be used in isolation to diagnose or determine the treatment plans, and they cannot be used to determine the treatment course also, right? As I said, don't disregard the class 2 DSA post-transplant because they identify a worse prognosis, and there are other markers of clinical status like simple things like creatinine values, etc. may be easier to monitor than the donor-specific antibody. So please bear that in mind also. Now, since we are talking so much of the mean fluorescence intensity or the MFI values, I thought that let us also understand the various factors that will affect these MFIs. So basically, the format of the testing, as I said, there are different beads. So they may have different antigen density also. There may be a lot to lot variability. There may be conformational changes of the antigens on the beads. In fact, in India, the single major challenge that we face is that most of these kits are manufactured in the Western world, and therefore they have all the conformations, all the antigens that are more native to their population. So certain things which are not there in our population or which our population possesses may not be represented at all in the test that we are using. So we have to keep all these things in mind also when we are looking at the results of our testing. Okay, so as I said, antigen density will vary. Other non-HLA antibodies will also non-specifically bind to various beads. So non-specific binding has to be kept in mind. Interference with various other factors when you are doing antibody testing is very important. And also sharing of target epitopes needs to be kept in mind when you are interpreting your antibody-based tests, right? So with this, I think we will be able to understand the limitations also of these assays, because the pooled antigen test or these assays as they are used, you may be using a class 1, class 2 screening, or you may be using just a lysate based cross match, etc. You need to know what are the limitations of these assays. Like the lysate based cross match may be missing your DP and DQ antibodies totally. Your pooled, as I said, the antigens may not be expressed properly and you may be missing on certain antibodies. So you need to understand the limitations of the assay format and therefore use two different tests which will complement each other. Therefore, a complete and accurate information about patient's HLA antibody is obtained with the use of more than one assay, right? So that is the bottom line which we need to understand. Right, so here is a very good reference table basically where the method, its description, its utility and the limitations have been summarized. So I'll just quickly highlight the most important points. So the traditional CDC cross-match, as we say, cytotoxicity cross-match, it will detect the antibodies in the recipient's serum which may bind to the donor cells and induce complement-mediated lysis. So here we are directly measuring the donor specific antibody. However, it is very difficult and prone to some irrelevant or indeterminate results. So you have flow cytometry, which is also now available, which will directly measure the donor specific antibody, and therefore the sensitivity is very much better than the CDC cross match. However, a lot of weak positive results, a lot of false positive results are a limitation of the flow cytometry cross match. Similarly, you may have the panel reactive antibody, as we said, the class 1, class 2 antibody screening, which does not identify specific HLA molecules to which the patient has antibodies, but it will give you an idea as to what is the extent of alloimmunization or immunization in your recipient, whether it is 10% or 20% or 30%. Single bead assays, as I said, are the best because they will give you the specific results, but there is no universal threshold for defining a positive assay in this case. And again, known false positives and false negative results are also possible in this case. There are now kits available for complement fixation single bead assays also, like C1q and C4d assays. So these are used to identify antibodies that can bind with HLA molecules and subsequently to exogenously added complement. And therefore, this will enable us to determine the specificity of the HLA molecule that is recognized. So these are the salient features of all the antibody testing mechanisms that we have currently. This also pictorial depiction of the same thing, basically, where the sensitivity increases with the solid phase assay and it is reduced at the level of the cell-based assays like the CDC cross-match. About Luminex based technology, we have already talked, so we can go further here. So basically, we come to the $1 million question, which test should be used? So here, what you should remember is the level of sensitivity. So as we say, the mandatory test is the CDC cross match even today, but you can enhance the sensitivity by adding AHG to your CDC cross match. And then if you have flow based cross match or a Luminex based cross match, the sensitivity will be much better. So you can use a combination of these. So either a CDC and flow or CDC and Luminex based cross match is something which most of the centers use for antibody identification or detection first. And for cytotoxicity, it is still best for clinically significant donor specific antibodies. So as I said, it is the mandatory test that is still followed, right? So with this, I would like to just share our algorithm at Kokilaben Dhirubhai Ambani Hospital, where we do HLA antibody testing. So first, whenever there is any patient, say for a bone marrow transplant, or there is a haploidentical transplant. So when it is just a fully matched bone marrow transplant, what is of paramount importance is doing a high resolution HLA typing. So you do that with your NGS. And if it is a solid organ transplant, then you can do an intermediate level or even a low resolution HLA typing, because that suffices. In both the cases, you will also do, especially in a haploidentical hematopoietic stem cell transplantation and in the solid organ transplantation, you will also screen the patient for HLA antibody analysis. Okay, so the first basic test, as I said, would be a T and B cell CDC cross match, which you will do, and parallelly you may also do a Luminex based DSA, donor specific antibody lysate cross match, right? So two different technologies. So you have the manual technique and the automated technique, the lysate based, Luminex based test. So if here your CDC results are negative, definitely you directly go in for a transplant. If they are positive, then you look at the antibody specificity by doing a single antigen bead test, and then there is a desensitization protocol. Again, you retest and look at the level of the antibody, whether it has reduced significantly, then go ahead for the transplant. As far as the lysate cross match is concerned, if it is negative and your CDC is also negative, yes, you go ahead with the transplant. But if it is positive, you again look at the specificity by doing a single antigen bead assay and then you decide whether to transplant or to go ahead for a desensitization protocol, right? So with this, again, the methods for antibody screening and cross matching in solid organ transplant basically. So here, as I said, CDC is the primary method, followed by modified flow cytometry technique. We do not use the ELISA based generic testing over here, specific or generic testing with ELISA, but we use the Luminex based testing over here, which gives us the important consideration of HLA antibodies basically, where we can detect the various spectrum of the HLA antibodies, and we can also speculate some quantification in terms of correlation with the MFI values that we are looking at. And then you have very specific tests, which are the single antigen bead test, which will give you a comprehensive specification of the HLA antibodies which you are dealing with in your patient. Next comes non-HLA antibodies. I'm sure most of you must have heard about even non-HLA antibodies. So HLA antibodies may be present, but at times along with these HLA antibodies or with absent HLA antibodies, you may have a non-specific reaction and you may wonder what is it because of. It may be commonly because of the non-HLA antibodies, and these are specifically seen in repeat transplant or retransplanted patients, or they are more in patients, male patients basically, who are young, at a young age they are getting transplanted, etc. And further testing for these non-HLA antibodies is often performed when there is histological evidence which suggests that there is a antibody mediated process and your HLA DSA test is negative. So that is your first telltale sign that there is a non-HLA antibody. Okay, so the commonest non-HLA antibody is this MIC-A antibody. So MIC-A stands for Major Histocompatibility Complex Class 1 Chain Related Gene A. Okay, so this is the commonest. So there are MIC-A kits that are available today, and this may occur in as high as about 13.9, so about 14% pre and post transplant, about 5% post transplant basically. Right. So these are complement activating and fixing antibodies, and they will activate the natural killer cells and lead to interaction with your various proteins in the donor organ and lead to rejection. Also, there are angiotensin 2 type 1 receptor antibodies or endothelin 1 type A receptor antibodies, etc. So all these are the other non-HLA antibodies. You will have anti-endothelial cell antibodies or the Perlecan or the LG3 antibodies, or the ICAM4, that is intercellular adhesion molecule 4 antibodies, anti-GBM antibodies, the glomerular basement membrane antibodies, etc. So these are a list of non-HLA antibodies. So please remember, in complicated cases where your donor specific antibody test is negative, you can test for non-HLA antibodies. There is a good chance that they may be present, right? So again, we come back to where we started. So clinical applications of HLA, as I said, stem cell transplant, solid organ transplant, but that's not all. There is also disease association, platelet transfusion. So for the alloimmunized patients, we may look at applet matching, and then those platelets may survive better, and a patient who is really perpetually at a risk of bleeding may be salvaged. Also, for patients who are at risk of TRALI, transfusion-related acute lung injury, or for prevention of certain drug-mediated reactions, and also in forensic sciences, there is a lot of application of HLA, basically, right? So as far as disease association is concerned, you may be looking at class 1. So HLA class 1 genes are mainly associated with, say, occurrence of leprosy, multiple sclerosis, lymphoid leukemias, Rh isoimmunizations, psoriasis, ankylosing spondylitis, hemophilia, malaria, and various susceptibility to or resistance to HIV-1 or type 1 autoimmune hepatitis, ANCA positive autoimmune disease, etc. Whereas class 2 genes are associated with multiple sclerosis, SLE, asthma, psoriasis, childhood ALL, or HIV-related disease, thyroid carcinomas, nephropathies, Kawasaki's disease, celiac disease, etc. So you may have a situation where the clinician may want you to test for one particular class 1 or class 2 HLA gene also, because he wants to establish the clinical diagnosis that he is suspecting in his patient, right? So as far as drug reactions are concerned, these are the most common requests that we get. So if a patient is to be started on antiretroviral therapy, most commonly abacavir is the drug that is used, but you look for a particular HLA locus, that is HLA B5701. If this is present, then there may be sensitivity to abacavir. Similarly, for patients with epilepsy, where you use carbamazepine, you may want to look for HLA-B15O2 before starting the therapy. Or when you are managing gout or hyperuricemia, you may want to look for B5801 before starting allopurinol. So that is the application of HLA in adverse drug reaction testing. So that's it, friends. This was just a sum up of all the applications of HLA testing in the clinical practice. So it is not only transplants, majority transplants, yes, but a lot of other applications now, including disease association. So HLA is a very dynamic field basically, and it has evolved, and every year we see that more and more with improving molecular techniques, more and more information about the unknown HLA antigens, HLA alleles is increasing our knowledge and also increasing the confusion around our current knowledge, I must say. So that's it, friends. I hope I am able to simplify a little bit about the complex topic of HLA. If there are any questions, I'll be happy to answer them. And if Dr. Naveen Khatri has joined us, I would invite him to, start the discussion.
Naveen Khatri sir, are you here? Sir, in chat box there are few questions.
Yes.
So one is, there is any effect of IV immunoglobulin infusions given in the desensitization protocol on DSA level? And can IV IG falsely raise the DSA level?
Yes, so it is very important, to share the treatment history and all the other sensitizing events history also when you investigate your patients for these HLA antibodies, because based on that, your clinical interpretation will differ. So IVIG, if given within a certain period, so especially if it is being given within 7 to 15 days, then that may cause some aberrant results in your Luminex or the antibody testing.
Okay. Sir, other one is, they are saying thank you sir for such a crisp and enlightening session. And one question is more, sir, please explain flow chart of HLA laboratory once again, if possible.
Flow chart of HLA laboratory. So is my slide visible there?
No, sir, no, not yet.
Just a minute. Can you see it now?
Yes, sir.
So flow chart of HLA laboratory. I'm not sure which chart.
I think, sir, the last one you have shown the.
About the methods, is it?
No, sir, I think they are asking about the flow chart which you are using in the
The
copying.
algorithm.
Yes, yes,
Oh, this
algorithm.
algorithm. Okay, so yes, I'll definitely repeat this. So as I said, the first test that is indicated is HLA typing. So depending upon the scenario, if you are dealing with a hematopoietic stem cell transplant, you may want to do a highest resolution typing because you want a perfect match between the donor and the recipient. If you are dealing with a solid organ transplant, then you may just want to do a medium level resolution or a low level resolution also, and that is fine for a solid organ transplant. So that is about typing. From the antibody point of view, you will now screen your patient or the recipient for any HLA antibody, and you will also look at donor specific antibody. So here what we do is we do a CDC cross match, which is the basic test which will detect the presence of antibodies in the recipient against any donor cells. Basically, the uh, broader evidence for presence of any antibodies which can be dangerous for the graft. Also, since two technologies are needed, we will also do a Luminex based lysate cross match, which is again, I said, a basic test like we do cross matching of blood. Correct. So lysate based cross match is done, and based on the results of these, so if your CDC is negative and your lysate based cross match is negative, then you go ahead with the transplant. There is minimal risk that is there. But if these are positive, then you may want to do the further confirmatory testing by doing a single antigen bead assay and understanding the specificity of the antibody. So suppose you identify an antibody which is specific to one particular HLA allele. Okay, so suppose if it is against say HLA-B52 and your donor does not have HLA-B52, he is negative. So there is antibody present, true, in the patient, but it is not donor specific. So then, even though the antibody is present, it may not be of that clinical significance. But if that B52 is present in the donor, then it is very donor specific and it is going to cause problems. So you start your desensitization and then you repeat your test and look at the effect of your desensitization. If it has occurred properly, then you can go ahead with the transplant. So is it clear now?
Thank you, sir. And
Sure.
the next question is it necessary to characterize the HL antibody in BMT once we find it's positive? So the same.
Yes, so the same approach as I said, if it is positive, then next step is you identify whether it is specific to the donor. So you have the HLA type of the donor already, right? You have done it as the first step towards transplant. And you have the antibody result also. You just match that antibody specificity with the donor HLA type. And if that particular HLA type is absent in the donor, then you are still okay to go ahead. If it is present, that means it is going to be a dangerous antibody and you have to take measures to reduce that antibody's level.
So the other question, how will you suggest to follow up the HL antibody titer post BMT after desensitization?
So after desensitization, what generally is recommended is that within the first month of the infusion, when there is engraftment, post engraftment, in the second or the third week, you should do one antibody screening assay and then do it at the end of the third month and at the end of the sixth month and then at the end of 1 year. So that is the protocol that many centers do follow. After that, depending upon the clinical picture, the clinical presentation of the patient, you can do it every 6 months also.
Thank you, sir. One question is again, which type of instrument is required for HLA typing? If we want learn transplant pathology, what are the options after the MD pathology?
Yeah, so the instruments, as I showed you, these are available. There are various platforms that are available. Basically for your antibody testing, so the first setup that you will need is to be able to perform a CDC cross match, a T and B cell cross match. And then you will need a platform for your HLA typing and your antibody testing also. So which generally is either Mr. Spot or Luminex. Both are available in India, so there's absolutely no problem. As far as learning transplant immunology is concerned, there are training programs, there are workshops that are done at the national level for transplant immunology. Generally, these are attended by most of the transfusion medicine postgraduates And in fact, there are the American Association, they have some good training programs, distance learning programs also for transplant immunology, which go on for 6 weeks period, etc. And they are also considered to be very good. And of course, there is a lot of scope because transplant in general is increasing not only in India, worldwide. So a good knowledge about immunology, transplant immunology, monitoring, counseling is very, very important. So this is now of not only of the interest of pathologist or transfusion medicine specialist, but also nephrologist do get trained a lot in transplant immunology, and also the other specialties now. So the cardiac transplanters and various other, so solid organ transplanters, also liver transplant team, they all also go into the basic training of immunology.
Thank you, sir. Thank you so much. I think Sir Naveen Khatri sir is not joined yet.
Right.
We- Sir, one more question is there. What will be the basic HLA antibody test you will suggest for any new BMT center? Is there any effect on transported sample?
Uh, no, generally, it is okay to transport samples. That's not a problem. The samples need to be separated and then sent. For typing, it is absolutely so. You can just take the buccal swab and send it for HLA typing. That's absolutely okay. And there's nothing like a basic test. So if you are planning to start a histocompatibility laboratory, as I said, you should be able to do at least the CDC cross match, which is the basic, still the gold standard test renal transplants at least. And you should have at least a setup like Luminex platform, for example, where you are able to do your HLA typing up to the intermediate level also, or at least the low level HLA typing, and you are able to screen your antibodies also. So that should be good enough. If you have the setup in your molecular laboratory for NGS, then you can use that for your high resolution typing also.
Sir, someone is asking any chance of any observership in your institute, sir?
Yes, definitely. We do welcome observers. We do get observers for HLA laboratory. So yes, you can just write an email and we will respond to you.
Thank you so much, sir. So it's very wonderful talk on this rare topic, HLA, but it's very pronounced topic nowadays. Thank you
Yes,
so
so I
much.
hope, I mean, I did not complicate it much. I thought we should keep it simple. So yes, I think I need to put in my email ID here, no? So just a minute. Not able to see the chat box here.
Sir, it will be on the right corner, lower corner.